chances of spontaneous conception. Now, the same patient, after laparoscopy, what was found is an ovarian cyst, so cystectomy was done. This an ablation of superficial peritoneal endometriosis was done. So, patency was again confirmed by laparoscopy. So, comma perturbation. So, in these situations, it is maybe offered the patient's ovulation induction and intrauterine insemination. In those situations, if the patient is a symptomatic, so laparoscopy followed by ovulation induction may be helpful. So, in the postoperative, that is in compared to expected management, and if there is a ovulation induction and intrauterine insemination give much more success in compared to expected management or ovulation induction or intrauterine insemination alone. So the thinking in recommendation is that in infertile women in earlier stage in endometriosis, it is the ovulation induction with intrauterine insemination after surgery has much better success rate. So this is again the one patient that is 28-year-old woman, married for 4 years, failed to conceive from last 2 years. Menstrual history is regular. She was evaluated for infertility and already received ovulation induction 3 cycles by chronic consulted by different specialists outside or etc. So the patient once the uterus was normal. What was on the finding was that an endometrium of 4 into 5 centimeter. So the hormonal profiles were normal and all the tubal test and husband semen analysis was normal. So in this patient, the patient is a first time presenting and there is endometriosis. So again, this patient will be beneficial with the laparoscopy and doing a ovarian cystectomy. The patient is young. So after the surgery, the patient will get better actually ovulation induction and intrauterine insemination. That will be the better situation. Now, sometimes what is the toxic GCPR is again, I just want to touch on that is when there is after assessment, if there is a tubal factor, male factor, and poor ovarian reserve. Now, when there is a young patient and infertility duration is less. So, young patient less than 30 years, less than 33 years duration infertility. So, in these patients, that is, if there is not symptomatic, so maybe 3 to 6 cycles, you can give the stimulation for a little bit of longer. But if the patient is older, like more than 30 years of ovarian reserve is less, so maybe giving some less cycles of induction and followed by if the patient is not able to conceive, maybe ART will be helpful in those patients. Now, considering this is another patient, 36-year-old woman, married for 8 years, trying to conceive from last 7 years. Now, this is patient's again menstrual history is more or less regular, and she already operated for large endometriosis. That is she had already operated for a big cyst and outside, and 2 years back followed by 4 cycles of ovulation. So if she had already surgery, she had ovulation induction, she failed to conceive. Now the transvaginal ultrasound, so this time again an endometrioma that is 5 into 5 centimeter, and all the hormonal profile, the it is normal except that AMH is in the lower category 1.1 nanogram per ml, and the husband semen is also normal. So in these situations, that is how to go, and this is in this patient. Now we'll have to remember this is not a fresh patient or a fresh endometrioma. The patient is already has been operated, and the elderly patient AMH is low. So in this situation, it is better to avoid surgery. That is in elderly patient, AMH is less and already has been surgery, because further surgery may compromise the ovarian function. That is what also the guidelines says. So in this patient, the analysis agonist for 3 months followed by IVF will be the weight management. That is to the patient who go for directly for IVF. So this is again whether the patient's reserve is good reserve or poor reserve. If the good reserve ovarian reserve, no, so we can consider some of the factors whether to go for surgery or whether go for directly ERT. So if the laparoscopy, that is symptomatic patient as we have told pain, or if indicated, or repeat surgery to be avoided. So almost is all the HT guidelines as well as the Fox says repeat surgery with endometrioma to be avoided. So if there is a poor ovarian reserve, you need to go for ERT. Now, whether this is an ultra long protocol or an antagonist protocol, so you can decide again on the ovarian reserve protocol. Now, to recapitulate, that is why the woman who is presented with infertility, we consider fertility factors, that is ovarian reserve, tubal analysis, that is by laparoscopy if required, sometime on the semen analysis. So if the natural conception is possible, even endometriosis patient, suppose the patient is having endometriosis is not so much symptomatic. So if the patient having severe pain, so symptomatic patient, laparoscopy is the thing need to consider. Now in the laparoscopy, if we see grade 4 endometriosis, that is severe endometriosis, the patient will go for directly IVF. If grade 1 to 3 endometriosis, maybe if the patient they consider if no pain, that means if there is severe pain, so that is after considering laparoscopy, so patient will go ovulation induction plus IUI for 4 to 6 cycles. If the patient fails to conceive, the reasonably period maybe 6 months or like that, then the patient will go for IVF. Now, if there is a previous surgery, as we have already told, or high age or large cyst, it's better to avoid surgery in those situations. That is, offer egg or embryo freezing, and maybe we'll go for this in the IVF is better in these situations patients. Now, if the patient is not having pain, like not symptom, and endometriosis is there, so it is in the first instance in those sentences it is better to start an ovulation induction for 4 to 6 cycles, as in the previous we have mentioned when the patient is young or old and fertility. So consider how many cycles of ovulation induction we can consider. It depends upon the age of the patient, the duration of the fertility. But considering there is giving an ovulation induction and intrauterine insemination for 3 to 6 cycles, and the patient fails to conceive, then later on may be considered for IVF. So if some patients sometimes maybe if there is no pain and not able to conceive after giving ovulation induction plus intrauterine insemination, then maybe can consider again laparoscopy before going and in vitro fertilization. That is many times it is done like that. Now, if the patient will consider assessing the ovarian reserve on all the other situations, that is the patient actually needs IVF, considering male factor, female factor, and poor ovarian reserve. In those situations, in situations to consider directly for IVF, and if laparoscopy is only to be considered if there is patient is severely symptomatic or inaccessible ovaries, then it is laparoscopy. Otherwise, patient will go for egg collection and freezing of all. So that is about how on this. Now, this surgery for an ovarian endometrium we have touched upon a bit, but it is cystectomy is the one which is recommended. It is controversial if cumulative pregnancy rate is more or higher, that is how many the rate is there, but it is seen that patient has first pregnancy in infertile patient has significantly shorter duration. That is, patient conceives sooner if there is a patient goes for cystectomy, especially in the first time patients. But always management should be the individuals. Now the surgery is, as we have mentioned, it is cystectomy is the preferred surgery in compared to the drainage and coagulation. For deep endometriosis, again, it has been whatever the ASHRAE guideline says, that is an infertile woman with infertility, severe pelvic pain, who are resistant to medical or severe bowel stenosis. Here, it's better to go for surgery, since there is a radical accession of endometriosis lesion as far as possible, along with outside and resection. So patient gives symptoms also, and later on the patient can be taken for the ART treatment. Now this is again because we many times get the ovarian endometrioma to make it simplified, because there is sometimes how many cysts, whether 3 centimeter, 4 centimeter, 5 centimeter. We need to decide on some guidelines, and in the case of Foxy GCPR gives on a guideline. If an ovarian endometrioma is a fresh one, and the size we consider. So fresh means first time presentation, and size is how much centimeter is there. So if it is less than or equal to 3 centimeter, it is advised that no surgery is required and patient can go for intrauterine insemination. If that fails, the patient fails to conceive, then go for ART or assisted reproductive treatment. Now, if the size is more than 3 centimeter in a first time presentation of endometrioma, then that is if the size is marking is taken cystectomy, and especially if the patient is symptomatic, and consider about the decrease of ovarian reserve, that is all it should be explained in this patient. Now, if there is an endometrioma which was previously operated, as we have found in one of the patients, so no repeat surgery, and the patient will go directly for ART, whether maybe it is Celtic or ovum dilation, oocyte dilation. That is the thing is recommended. So that means I try to concise on that is infertility and endometriosis. Thank you so much.
Thank you. You presented it brilliant. Thank you so much. I think we'll pick up the questions after the end of the session. And so we proceed to the next speaker.
Next speaker is Dr. Jyotimala Bordoloi Bhattacharya.
May I request our chairperson, sir, to kindly introduce Dr. Jyotimala Bordoloi Bhattacharya, ma'am.
Dr. Jyotimala Bordoloi, she is a consultant obstetrician and gynecologist in Preschool Polyclinic and Hospital. And she is an IBS and practice specialist. Please, Pati.
Thank you, sir. Ma'am, sorry for the inconvenience.
Good morning, everybody. Respected chairpersons, my teachers, my seniors, my friends, and also the organizing secretary and the organizing committee for having me over here in Jorhat. It's a real pleasure. So without wasting much more time, today my topic is polycystic ovarian syndrome and infertility and the impact it has on women. And today we are going to, the presentation is basically, it's going to be about how we manage PCOS and the challenges that we face in our day-to-day management. So this is a common case scenario that we face in our day-to-day practice. This is a 30-year-old married woman with history of irregular menstrual cycles, acne, hirsutism since menarche. Her BMI is high. She's anxious to have a baby for the past 2 years and she takes tablets on and off for her periods, which was prescribed by her gynecologist when she was 18 years. So all of us must have faced situations like this. So we know that polycystic ovarian syndrome, this lady which has come, it's probably a diagnosis of polycystic ovarian syndrome, as irregular menstrual cycles are because of anovulation commonly. The features are of hyperandrogenism, and if we do a TVS, transvaginal sonography, we will find more than 12 follicles measuring 0.2 to 0.9 centimeter in one or both ovaries, and the ovarian volume is more than 10 centimeter cube. And then when PCOS, we have to rule out other causes of hyperandrogenism, like thyroid dysfunction, hyperprolactinemia, pituitary gland disease, premature ovarian failure, Cushing's syndrome. And it is interesting to know that very often in 30-year-old women who comes with menstrual irregularity, we jump to the conclusion of that she might be suffering from PCOS, but we might have also come across patients, very young patients who must have been suffering from premature ovarian failure. Patients, like 15 to 20% cases of PCOS have hyperprolactinemia. So the etiology is unclear in PCOS patients, like 15 to 20% cases of PCOS have hyperprolactinemia. So the etiology is unclear, it's complicated, but it is very, very common. 1 in 10 women suffer from PCOS, and 30% amounts to 30% cases of infertility, and of all the ambulatory infertility. So this is the kind of impact it has on a woman's life, starting from adolescence to menopause, and infertility is what we are going to talk about today. So you can imagine the impact it has on a woman. It not only affects the physical health, but also the emotional well-being, depressive and anxiety symptoms, psychosexual sex life and relationships, and overall it becomes a vicious cycle which further contributes to infertility. So the basic etiopathogenesis is insulin resistance, we all know, and it leads to hyperandrogenemia, high LH levels, and especially in obese women, and also in lean PCOS. What we are worried about is the central obesity. Lean PCOS, although they might be, their BMI might be low, but we have to look into the waist-hip ratio. That is very, very important. And these are the major determinants of, and the major markers of insulin resistance. So excess of body fat aggravates insulin resistance. And like I said, in lean varieties also, we have to look at the waist-hip ratio. That is very important when we especially counsel them about lifestyle management and like controlling weight, because lean PCOS patients, like if you say that you do a diet modification or exercise, are not very accepting. So in those cases, waist-hip ratio is a very important factor. In women, as per WHO guidelines, we have to have a waist-hip ratio below 0.85. Again, coming back to the same case, so the woman comes to us and she's trying to. The first question she would ask, like when you tell her that she has got PCOS, is PCOS curable? Can I become pregnant? Actually, we all know that PCOS is not curable because it stays with us till menopause in various manifestations, starting from adolescence to menopause. In menopause, we end up with metabolic syndrome if we do not take care. But if she says that you can become pregnant, we say yes, it is manageable. There are various ways how to do that. And in such women, the basic principle is that we have to approach them with a very compassionate approach. We have to individualize each patient, and this will give us the best possible reproductive outcome. So like Hafizur has said, that infertility is a very depressing word. So most fertility consultants would use the term subfertility. It basically means reduced fertility, and it takes some time to conception. So with proper management treatment, these patients can become pregnant, and PCOS is a classic example. Subfertility sounds more optimistic for the patients, and it gives them a ray of hope instead of using the word infertility for them. So I'll start my presentation again with a different subtitle now. PCOS and subfertility, we are going to discuss how we are going to go about it. So like I said, a stepwise compassionate approach, individualizing the treatment, and most importantly that we are treating patients, but we have to keep ourselves abreast with the recent and updated treatment plans and guidelines. And so that because we have to keep ourselves updated because of it helps us in patient counseling, and to tell them that it's an evidence based practice that we are following in treating them. So like I said, emotional health and counseling plays a very important part when we are taking a patient for treatment. We have to counsel them starting from the lifestyle, like what kind of treatment we are going to do for them, be it tablets,